we'll move to the next session. Thank you very much. And the next session is about circulatory support, and where may I invite Dr. Pradeep Yadav from Atlanta, USA, Dr. Hani Reghi, Dr. Khalid Al-Shebi, Dr. Suman Bhandari, and Dr. C.N. Makle from Pune to please join us on the expert panel. Thank you very much. Thanks a lot. Thanks a lot. Lovely. Classic. Pradeep, come. And can I also request Dr. Ravi Dalmia, Dr. R.D. Pandey, Dr. Asim Dhal, Dr. S.S. Murthy, Dr. Babu Ezumalai, Dhruv Sharma, Dilip Tiwari. Please join us on the discussion. Achha. All right. So we have first a very interesting basic talk from Dr. Sanjog Kalra. I asked him that Sanjog, let's have some 10 commandments like everybody else is sharing with us. So Sanjog said, no, I'll put everything in a nutshell and make it five tips for circulatory support. So circulatory support is a big thing now with the complexity of interventions going up, and most of us want to be familiar with it and see wherever possible we can use them. So over to you, Sanjog, for your presentation.
Thank you very, very much. I'm sure you guys are getting probably pretty bored of listening to me, so I'll try to keep this quick. So my bona fides are, I do on average, while I was in the US, I did about 50 to 60 Impellas a year. I did 15 to 20 ECMOs a year. I did a little bit of tandem heart work, not that many balloon pumps. Since coming to Canada, those numbers have changed actually. So now my tandem heart volumes, ECMO volumes have gone up. Impella volumes have come down a little bit. Balloon pump volumes go up. So it's largely a cost-driven enterprise. But once again, this is the wrong talk you put up. Once again, this comes down to doing what's right for a patient, right? Picking the therapy that's necessary to be able to get us the very best results that we can get. Why is that doing that? Oh, well, this is the wrong title slide, so I'll leave it here. Getting us the very best results that we can, and that means that doing whatever we choose to do, we do it using best-in-class techniques, okay? So some of you may have seen this case. So this is just a quick representative case to wet the whistle, if you will. This is a 74-year-old who has the usual cardiac risk factors, who has bad peripheral arterial disease, who presents with bad CCS class 3 angina and is already on multiple antianginals. And the back history of this patient is he underwent CABG several years prior, right? So he had a lima to the LAD, an SVG to the OM, and the SVG to the diagonal. And he was improved following the CABG, but then unfortunately had a failure of his saphenous vein graft to the dominant circ. This underwent PCI that same year in 2014, and then again in 2018. So it was left main into the circumflex. There was no IVUS used. There was clear calcification. There's a nice pathologic paper, actually a histology paper that you can read that's come out in the last couple of years that talks about the amount of calcium post-bypass and how it goes up. So not surprisingly, there's probably some stent under expansion there. And now he comes in with bad symptoms and a drop in his EF to 20%. And so here's the problem, right? So he's got now 2 layers of stents, and he's got bad in-stent restenosis at the level of the left main going into the circ that's isolating a big, juicy, dominant circumflex. It's a recurrent stenosis. It's an important territory. He's got peripheral arterial disease. He's not a candidate for repeat bypass, and he is the father of one of my colleagues. So now how do you do this case? This guy with EF of 20% where you know that you're going to be up for extended periods of time in the left main trying to get this open. These were the initial hemodynamics, right? So we can go through these in significant detail, maybe offline, just because of the amount of time that we have. But really what's important to look at here is that the cardiac power output, the only hemodynamic correlative mortality out of the shock registry, is well below 1. It's at 0.69. We know out of data from the Cardiogenic Shock Initiative that once you're getting below 0.6, your outcomes really start to drop. The key is that there's a cardiac index of 2.1, so this patient's in a low flow state already, right? It's not a surprise that, with an EF of 20%, you're really just compensated. So the question is, do you use MCS for this case? Somebody with an EF of 20%, a dominant circumflex, with a graft that's down, a small diagonal that's grafted but not really worth much, and an LAD that has an open lima but with a long CTO segment, under an EF of 20% with some degree of MR. How do you approach that? Well, what are we trying to accomplish? Right? What is it that we're trying to earn? MCS is there to maintain hemodynamics. It's to make sure that the patient's body that is already stressed does not take recurrent hit after hit when we do the things that we do to be able to fix their coronaries. Contrast does not contain hemoglobin, right? When we put balloons up, we block blood flow to the heart, we stun the myocardium. So we recognize then that there is a double-edged sword to that. And the sooner one recognizes that anytime you mess around in the heart, you create the potential for injuring LV function, the faster we're going to get at being able to spot trouble when it's coming. The other key is to facilitate complete and optimal revascularization, right? So this guy's already been through 2 procedures and a cabbage and has failed. So why has he failed is probably the first question we should ask. And then once we've asked that and answered that question, we should work on making sure that he doesn't fail a 3rd time. And then, of course, maintain case safety. So tip number 1, patient selection is everything. We've all seen this Venn diagram where it talks about patient comorbidities combined with complex coronary disease, combined with complex hemodynamics. And that when these 3 things confluence together, that's what becomes the sort of CHIP patient. But what does that actually mean? On the patient comorbidity side, when looking at groups of patients that are turned down for surgery, what we see is that only half of them are because of age. The other half are because of typical comorbidities that we see, the chief amongst them being severely reduced kidney function, because we know that these individuals do very badly when they develop CIN, much worse than the average individual without kidney disease. Hemodynamics compromise, so specifically high left ventricular end diastolic pressures, low cardiac outputs and indices, big dilated ventricles, these are people that already have no reserve. So they're not going to tolerate another hit. And then, of course, complex coronary disease, like, for example, 2 layers of stent in the left main already. So the questions to ask are, what is truly high risk? Do we use this up front? How much support is necessary? Is a CP enough? Do you need a 5.0 or is a 2.5, which what in my personal opinion is basically a Kelowna for a tiny little, elderly lady? Is that going to be enough? It's certainly not a shock device. And then where is the relevance of risk versus benefit versus cost? Because these devices are not free. And then of course, what's your operator skill set? And those of us who do a lot of hemodynamic support, I think, are more and more aware of how little we know about how to manage these devices after the procedure is done. Because what we're doing to patients now in these procedures, we never did before. So the shock phenotype that comes out after the case is not something that we've ever seen before. It's this weird multimodal hemometabolic hemodynamic shock with circulating inflammatory mediators that behave like a summated vasodilatory vasoconstrictive shock with a poor cardiac output and a stunned myocardium. How do you manage that when you have no flow from left to right, right? So that comes down to the operator skill set as well as the skill set in the critical care unit. And that's why we always have to balance the risks, so bleeding after large bore access versus the benefits of complete revascularization and what it takes to get there. So when should we consider support? When either you have LV dysfunction or irreversible hemodynamic perturbation in the setting of ischemic stress and a contrast load, or LV dysfunction with one of these other things, difficult wiring, likely difficulty in stent deliveries, a high risk of no reflow, retrograde CTO through an only remaining conduit or through a major vessel. So what are the questions that I typically ask? Is the patient hemodynamically deranged despite medical optimization? If yes, support, because that's a shock patient. If no, go to your next question. Does the patient have the reserve to sustain a significant hemodynamic hit for a short period? So is this someone who's got an EF of 20% in an RV that's down with MR and terrible coronaries already? Or is this somebody who has a relatively normal EF who, if they lose their LAD for 30 minutes, is no different than the STEMI that we see every day? If no, consider support. If yes, go to the next question. Is the patient at risk for a complete interruption of blood supply? So are you working on an only remaining conduit that supplies multiple CTO areas? For example, if yes, support. If no, next question. And it's important to say that this is about high-risk PCI, not about cardiogenic shock. Cardiogenic shock is a completely different beast, okay? And then the fourth question is the patient at risk for a prolonged ischemic insult, limiting my ability to completely revascularize when complete revascularization is what they're going to benefit from? So I'm not talking about completely revascularizing the right CTO and the left main and every branch vessel in the 91-year-old who does nothing, right? We're talking about one of you who is fully functional and has a job to do, and so we need to give you the resources to get to where you need to go. If the answer is yes, support that patient. If not, at minimum, get bilateral access so you can get on to support quickly, though we have data to show that the faster you get on, the better off you are. So this is just to say that I'm not a pump head, right? I do lots of complex cases. This is the majority of my practice, but as you'll see, the overwhelming majority of my cases are not on support, right? Like, I mean, I think if I look at my total number of cases in the last 2 years, I mean, I'm looking at sort of 50 pumps or so, which in the context of my practice is a lot because this is all I see. Tip number 2, hemodynamics are critical to track both efficacy and weaning. Okay, so we talked about why LV patients are so high risk, right? You get recurrent ischemic hits every time you try to fix them. Gear obstructs flow, wires and balloons obstruct flow, et cetera, et cetera. And this is an old study that looked at GLP-1 as a tracer in patients who in pigs who had had recurrent ischemia induced, and what they actually found was an area of myocardial stunning that occurred following recurrent ischemic hits in the setting of a PCI, right? So this tells you that recurrent ischemia in these low EFs actually has consequences. It's not a benign problem to have. And what we recognize is that in patients who have recurrent hits to their coronary perfusion, their LV function does get worse. And we also know that MCS augments coronary perfusion pressure by reducing left ventricular and diastolic pressure and increasing your MAP. So you're sort of solving the underlying problems, right? But you only know those underlying problems if you've actually assessed the hemodynamics. So the lesson is the heart is generally worse immediately after you're done, not better. And so you're actually best at the start of your high-risk case. So if your case is going to get bad, if you have a really nasty set of work to do, that is, after you started is not the time when you should be considering your support. It's up front before you take the hit. This is the sort of Smart Assist screen. These are the hemodynamics that you get on a Smart Assist, where you actually get a cardiac output, you get a cardiac index, you get a native cardiac output and an assisted output, as well as your usual LVDP and placement signals. And what you see then when you try to wean is as you reduce the flows of the device, you should see a maintenance or increase of the native output and a decrease of the machine output. If you don't see that, you're not ready to wean, because it means that you've still got a heart that's having trouble keeping up with what the body's demands are. And that was the whole point of putting the pump in the first place. There seems to be this rush to pull the pump out. And this is all about the skill set in the ICU. So general rules, your native cardiac output at P2 should be going equal or better than what you started with. If it's not, don't take the pump out. As the Impella is weaned, the output and index should be going up, and there should be no complications during your PCI. Number 3, and I have only a few minutes left. I see that I'm above time, so I'll rip through the last few. Number 3 is your battle is won and lost at the access, okay? We all have seen disasters happen at the leg, and we're all moving towards radial PCI because it's safer, right? But that doesn't mean that we can forget about how to do large bore femoral access. So I won't go through these particular details because I'm sure everybody knows how to do good large bore femoral access, but the key is, what happens if you don't pre-close this? Well, this is a reference for you about how you can post-close a 14 French hole, where you don't actually have to have the pre-closed sutures in. You can get 2 wires through the Impella so that it's actually sitting in the large bore access, and then you can individually pre-close on each wire, and you end up getting a very nice closure. Done many of these. I now do these Impella removals and closures at the bedside. And then, of course, the single axis technique was a large innovation that we demonstrated at CHIP CTO a couple of years ago and has been adopted. But has anybody ever seen dual catheter access in an Impella through an Impella sheath? So single dual, so that's what that looks like. So let's say you want to do a CTO and you need your distal vessel injected, and you need your Impella, and you need your guide. Here's how you do it. You put your Impella central, then your 6 French guide, preferably a slender sheath, because then you get a 5 outer, 6 inner, will go at roughly the 10 o'clock position. Same way you do a regular single access. And then you can put a 4 French for your distal injection, for your retrograde injection, at point C, so roughly about 4 o'clock. Don't hit the outer diaphragm. Skate just underneath the diaphragm within the sheath, and you'll be able to get both in. And then you have everything through one access. It saves your patient pain, if nothing else. And if this doesn't work, no big deal. Radial access on heparin is not dangerous. Number 4, ICU management is everything. Okay, they are more important than we are. Don't pretend. They are more important than we are, because we can do all kinds of funny things in the coronaries, but then if we walk away, the patient dies, right? So position issues are the most frequent problem encountered in the ICU. So never leave the cath lab without a really good, stable position established. You have to have unobstructed flow, you have to have no suction alarms, and you need to know that your hemodynamics are stable, because it's in the cath lab that you want to diagnose right heart failure. It's not in the CCU when you realize that you've overflown from your left side into your right side is bagged out, and now you need a right-sided support device or ECMO. That's to be done in the lab with your right heart cath. Your optimal positioning, I think we all know, you want your inflow cage roughly 3.5 centimeters from the level of your aortic valve, not tangled in the mitral valve. I tore a mitral valve out with an Impeller-50 a little while ago. I felt kind of bad about that. But you know what? It happens. And that's why the placement of your device is absolutely critical. It's all about the time you put in the lab. Know your console. Don't be afraid to touch your AIC. There's a lot of really useful information in there. So you have a placement signal here, you have a motor current here, and you have a reasonable Impeller flow. And yet there's a position warning. So what's going on? Well, this is where your hemodynamics come into place. Now when you look at the hemodynamics, you realize that the CVP is 3. And so it's telling you there's a push position alarm because the detector is not getting enough fluid, and you need to be able to give them more fluid or treat the bleeding, which is why they're leaving intravascular volume, or treat the hemolysis or whatever. And about hemolysis, there are 3 reasons for Impeller-related hemolysis. There is abnormal positioning, there's insufficient preload, and there's thrombosis. This is a really good review that came out yesterday, so it's hot off the press, okay? Thrombosis happens because you release a lot of inflammatory mediators when you have some hemolysis. Insufficient preload happens when you bleed or when you're too dry. And abnormal positioning is generally speaking because the device is too deep. All of these things can be easily corrected in the cath lab. The most common reason for this problem is a position problem. And so this is how you manage it. Cultivate a culture of migration. So know that when you go back to the ICU, every single time you put one of these in, the first thing the patient gets after being transferred is an echo. You establish that the position is good, you establish that the hemodynamics are where you need them to be, and then you start going after, is the right heart the problem or is the hemolysis the problem? So numbers 1, 2, 3, 4, and 5 are all position issues. And tip number 5, which is probably the most important because this is all very interesting to discuss, is don't forget the PCI. The purpose of mechanical circulatory support is to facilitate optimal and complete revascularization, not facilitate a big hole in the groin, right? This is the famous trial from the Syntax trial. I will submit to you that if you are the CABG center, you probably don't want to get CABG here, no more than you want to get PCI here. Not every operator is the same, not every patient's the same, not every case is the same. And so we need to be kind of honest about what we can and can't do well. And as a result, create networks where we can refer patients. This is from the ischemia trial. We say we didn't see a whole lot of difference in the ischemia trial, as we all know, though the curves really do start to separate the further out that you go. But when you look at pre-specified endpoints from the ischemia trial, and you look at the patients who had the most coronary disease, the higher the Duke score, the bigger the difference between these patients. This is the problem with randomized trials, right? We homogenize patients with confounders, and we hope that we get it right. But what the reality is of this trial is that symptoms are better with PCI, and when you're really sick and you have bad coronary disease, revascularization is better than medications. And that's why we see this when you look at patients with low EFs, whether it's this trial or another. So I'll stop here. I'll tell you quickly that at the end of our case, we put that balloon up. We put an NC balloon up in this guy's left knee, and I held it there for 3.5 minutes on an Impeller at maximum atmospheric pressures. That's how long it took to make that lesion pop. But when we walked away with a minimal stent area at the point of confluence of over 10. So this guy's not coming back. That's what it takes to be able to get the job done, right? And so hopefully you remember those 5 tips as a way of getting forward. Sorry for going over time.
Excellent, as predicted. So you have a total grip over circulatory support. Any comments from our experts? Pradeep, yeah.
Sanjog, that was a great presentation. Can you share your thoughts on selection of Impeller versus, say, let's say ECMO or
Yeah, great thought.
any of the tandem? Like, how do you
Absolutely.
process?
So here is the. Can you permit me to bring up one slide from a different talk? If you bear with me for just a quick second, this will lay it out. The ECMO is a loading condition. Okay, so your retroaortic flow from your ECMO return cannula is an LV loading condition. So typically, ECMO is for the patients who either have an oxygenation defect, have SCI-D proceeding to SCI-E cardiogenic shock, so profound shock, where we need full support, but it always comes with the caveat that you're going to have to do something to support the heart. That means you're going to do a septostomy, or you're going to put an LV vent in, whether that's an Impeller-2.5 or an Impeller-CPE or a balloon pump or whatever, it just depends on your patient. The other group of patients that do well with ECMO are some of the valvular lesions, not all of them, okay? With Impeller-5.0, you're talking about SCI-D shock or SCI-C proceeding to SCI-D shock, because those patients need more support than what the CP can give you. If you're looking at SCI-C going into SCI-D shock, so your lactates between like 2 and 5, your cardiac power output's 0.6, your RV is completely competent, that's an Impeller-CP patient. And so the mistake that we make in the shock space is to, A, mix apples and oranges by mixing high-risk PCI and shock. They're not the same, right? And then in the shock space, one must recognize that the further you're into shock, the worse a decision it is to escalate therapy, because what you're doing is burning through reserve. As a result, what you might consider doing, and this is a paper that we're writing, it should come out soon, it's called elevate, not escalate. So take your patient's SCI-D shock classification and hit them with the support that they need right away. So you don't burn through all the organ reserve that patient still has by slowly upgrading therapy as they fail. Then start pulling back the support technologies rather than allowing them to lose their organs, because those are the major determinants of your cardiogenic shock recovery, right? As far as tandem goes, tandem's a little bit of a different beast in that it requires a degree of technical ability, but it's a very good device. Tandems typically do well in patients who have the need for more support than a CP but don't need as much as an ECMO cannula, and who have bad MR. Because the tandem cannula will go across the septum and sit in the middle of the atrium and directly drain the left atrium with a retroaortic return cannula. So you do have a rise in the afterload, but your LV is empty. So the oxygen demand of that LV is very low. So it will tolerate that very, very well, and you can easily get, with a 21 return or even a 19 return and a 21 transeptal, you'll get 4.5, 5 liters of flow without breaking a sweat, right? It's a very good device that way.
Oh, that's great.
Honey.
Again, a fantastic presentation. Just a practical question. In your center, what is the threshold for dialysis, renal dialysis, hemodialysis for patients who are on Impeller, who are anuric? How early is the nephrologist involved, and who takes the decision, and how is it done?
So that's a good question. One of my other hats is I'm a critical care physician. So when I'm attending in the ICU, my approach to dealing with organ dysfunction is every minute is a minute wasted. So if I see someone going south, where their urine output is dropping, and it's very clear to me that it's an irreversible cause, it's either ATN or some sort of bleeding issue that's resulted in recurrent shock, or it's going to be CIN that's developing, or it's a low output state, I don't waste time, right? If it's a low output state, then you have something you can do about it, right? I'll upsize their support. But generally speaking, if it's anything else, you get the nephrologist involved very early. I'll usually get them a dialysis line in the cath lab before they go to the ICU, because it's a pain in the butt to put it in the ICU. Why wouldn't you put it in when you have fluoro and everything else at your disposal, right? Do it nice, clean with a micropuncture kit in the neck. And then as soon as they get back, if I call, so if the ICU attending calls and says, get down here. I don't like what I see. They will come. And if they say no, it's never a summarily saying no. It's generally speaking a discussion which says, I don't want to dialyze this patient right now because I'm worried about the hemodynamics, to which I usually respond, that's my job. You do your job, I'll do my job. And we get it done.
Excellent. Great. Thank you very much. Big hand. Dr. Yadav will make his comment while Dr. Seth is getting ready for his presentation.
Clear distinction between ECMO.
Talk. The recent propensity match patient of compared between IBP and Impeller, Impeller was found to be inferior. Even mortality is higher with the Impeller. So JAMA Internal Medicine just published few weeks ago.
The question was, there was a recent propensity matched cohort that was published in JAMA Cardiology, I believe. It was JAMA Internal Medicine, sorry. That was acute myocardiogenic shock that matched balloon pump patients to Impeller patients, and they found a higher mortality in the Impeller patients. The problem with those patients is the implant in the vast majority of those patients was after the PCI started, right? And that's not something that's typically measured. And there's very clear data to show that when you implant late, you get worse results. So imagine the cognitive dissonance for a second. I'm going to implant this, I'm going to start this case. Then the patient goes south. So now I've taken a hit, as opposed to the balloon pumps where they're going in early because the patient doesn't look good. And then after implanting an Impeller, I think to myself, okay, now I've got support on board, so now let's go to town. And every balloon is going up for 30 seconds and you're doing 4 vessels instead of doing the one culprit and getting out, which is what they did in the balloon pump, right? Or may have done in the balloon pump group, right? So this is the danger of propensity matched cohorts, right? There is a lot of unmeasured confounders here. And the signal, which is patients who are getting a support device are doing worse, is an important signal, right? And that's one that needs to be investigated. But that's part of what we're investigating in DTU STEMI, where we're looking at whether or not the problem is all a hemodynamic problem to start, and that we actually need to put the MI on the back burner. That's what we seem to learn even during the DTU pilot study, which I was a part of, where these were patients that were not in shock who got an Impeller, right? Who, in front of my eyes, I could not believe it. I would put an LV unloading device in and their ST segments would come down to normal, but their artery was still closed, right? So there's a lot, the answer to your question is I don't know, but there's a lot to learn here. And it's a signal that we need to investigate.
Thank you.
But that's what being looked at prospectively now. And
Yeah, that's our
that's
database.
the most important. That's
right?
the
That's our
prospective
database.
trial on at the moment. So I think we'll have answers to exactly those retrospective analysis, where the propensity match is fraught with a lot of issues.
Over to you, Ashok.
Yeah.
You look at retrospective analyses about revascularization.
So Sanjog,
shock,
I think
right?
we'll have a discussion at the end, but I'm going to talk about Impeller-Supported Pci. And won't take you through this, that those are already been discussed, but truly physiological in terms of support is what Impeller is, as opposed to ECMO, has just been discussed. Well, it was April 2007, a little bit of flashback, always throwback is important to put things into perspective in our Indian scenario. April 2007 was the first implant of Impeller. When I did that for Asia Pacific, in an 83-year-old guy who had borderline pressures, acute MI, previous triple vessel disease known, transferred on a ventilator with borderline pressures, with an ejection fraction of 30%, airlifted, and he was bad. He was bad, and put in an Impeller that was available just a few days earlier to that, and revascularized, triple vessel revascularization done with left main, as well as circumflex and right coronary arteries, and he lived. Well, we did enough cases in that year to be able to transmit the first ever Impeller cases to be transmitted to the TCT in 2007 to the main arena, as well as the coronary theater, and obviously commented upon as a beautiful demonstration of most treacherous cases that they'd actually witnessed. So that's our history when Impeller went out of our hands by a couple of years later, and then we introduced Impeller again in June of 2018, and that's where we stand. Now let me just take you through this case, and what's right with this case and what's wrong with the case. I think there's everything wrong with the case. The only right thing I did was actually put in an Impeller. But but the case went truly sour. And I think I present this case to you to understand how things can actually go sour because you just get up from the wrong side of the bed in the morning. As you want to do this live case, you don't get the Impeller CP. He brings you an Impeller 2.5, which is not what you want, because you want an Impeller CP, and then you have to wait for another 2 hours to get an Impeller CP. The sheath is wrong because you want to do a single axis impeller, and therefore that needs a 14 French Impeller CP sheath, and then the audiovisual is not working, and you're sort of tight for time. And this is what happens when you have a 78-year-old male diabetic, an anterior MI around 6 weeks earlier, and he had 2 subsequent admissions with left ventricular failure with an ejection fraction of 25%. An angiogram then also has already demonstrated severe calcific TVD. PET scan demonstrated viability in territories with partial anterior infarction. PA pressures were elevated. There was moderate MR. Obviously, that's his right coronary artery. It's calcific. Nothing big deal about the right coronary artery. Thought this would be a cakewalk on the right coronary artery. The left circumflex demonstrates high-grade stenosis before the 2 OMs. And of course, the first OM is occluded. The plan was to revascularize that OM as both the OMs as well. And of course, the LAD had demonstrated heavily calcified proximal LAD disease before a big bifurcation, and then diffuse disease thereafter, which we thought we would rotablate right to the end, and perhaps to do a balloon followed by drug-eluting balloon to the distal part, and then IVL to the proximal or whatever rotor. Anyway, like he said, we went ahead with the single axis, and by the way, this is live demonstration, and I therefore demonstrate to you single axis impeller. But I don't think I want to take you through all this. This has got a sound in it. It's a micro puncher needle. You come at the outer curve. You just puncture with a micro puncher needle, threading the wire. And after threading the wire, you just dilate that. You put in a 035 wire. You then dilate it and then put in what we call a Terumo destination sheath of 45 centimeters. That's lubricated, it's braided, it works very well for a single axis. So we went and did this single axis impeller for this and also demonstrated how to do single axis impeller. So that's our really live, this was live telecast and live demonstrated, and we're doing that. Not to take you through the case actually, the guiding catheter usually falls short with a single axis impeller unless you take longer guiding catheters, and that's because there's 8 to 10 centimeters of the sheath protruding out. Because that's not the lubricated part. But there's a whole lot of steps that you need to understand when you do single axis impeller, because you need to hold the impeller in its position while inserting the sheath, and you cannot displace the impeller. You can actually push it. You don't want to push it. You don't want to pull it back. Anyway, OCT could not cross. I wasn't able to interrogate this, so decided to dilate for an OCT. And as the balloon did cross, so I said, let's go ahead and dilate it, had an indentation. And that's the stupidity of life when you're just proceeding along on a spinal level, that you actually then don't think that this actually should have been rotablated at that time, rather than just proceeded with the balloon angioplasty. And of course, as we proceeded with the balloon angioplasty, it showed indentation, and one decided to go ahead with even a 2 millimeter OPN balloon and dilate it to 35 atmospheres. And obviously then one had committed to be proceeding further to using intravascular lithotripsy, still not having imaged the vessel, to decide about what to do. So these were constraints already of a bad day, which had started off unfair because 80 pulses got delivered and then you still have an indentation on this case. And therefore, it's clear that this is a nodular calcification. And one should have foreseen that. And that's where rotational atherectomy takes an advantage over IVL, in the fact that guide wire biases would have ablated that nodular calcium extremely well and should have been the device of choice. But unfortunately, we had moved ahead. After 80 pulses, we were able to image it and understand that there was deep calcification. But then I thought that we actually had numerous cracks and fissures with IVL, enough to give me a good lumen. And there's another mistake I made. I should have actually then gone in, understood the fact that it was a 3 millimeter vessel, taken at least a 2.75 millimeter high pressure balloon, which I always educate, and actually seen no waste on it in 2 orthogonal planes. And then I should have put in a stent. And of course, I didn't do that. So I actually then put in a stent, 2.75, 38 Zions expedition. And here it is. It seems very, very, very well expanded. But of course, when you do imaging, you realize that there are numerous areas which haven't expanded, which are under underdone. That's all because of nodular calcification and deep eccentric calcification, which actually has not been disrupted by IVL. So here again one goes in with an OPN at 40 atmospheres, at 3 millimeter now, and that of course gets you a good result with a good optimization. But look at the number of steps which I took to get an optimal result in a scenario where all it should have been was a rotational atherectomy followed by an imaging would have told me all that prior up front. Then I proceeded and I would have actually got that. But things got worse as we went along the left side. So till now everything's been fine, and we went along this circumflex and dilated and put in a stent, and lo and behold, soon after that the patient had slow flow, it was hypotension. Patient started having chest pain, ST segment changes, slow flow all over, and the heart was stopping. And I think this was dramatic air embolism, which occurred all downstream. It took us 10 minutes to revive this patient. Actually, this was a live case that we were recording, and then we got him finally with auto perfusion. Luckily, the Impeller was there to support the patient, and I think that's where I thank the fact that we had Impeller in a CP in a situation of a complete closure of the left system, as you can actually see. Well, finally, 10 minutes later, I recovered auto perfusion, decided to go ahead with rotational atherectomy to the LAD, and of course a 1.5 bar as it is, getting impatient with everything that was going on. Perhaps gave not enough time in this vessel, which was the culprit vessel, for acute MI, though it was a month ago. And there I go. That's very fast. Slow flow in the LAD, again closure of the vessels, as you can see, closure of the branches. Again, ST segment changes, chest pain, hypertension, and again cessation or practically slow flow down vessels. Well, that actually led to the fact that we then, of course, did what we had to restore flow. But the flow got restored, but the diagonal actually had no flow. When the diagonal had no flow, we then proceeded. And then, of course, the diagonal was pinched. I think we went across the diagonal, and you can actually see cessation of flow in the diagonal. Finally dilated the diagonal, and then had a dissection in the diagonal. So finally tapped the diagonal. Still, the patient maintained on Impeller. This was a disastrous consequences when you think that the PA pressures were 60 and 70, and the systemic pressures, of course, were Impeller supported in a guy with 25% ejection fraction. These were not good things. So we decided to leave that distal lesion, which we thought we'd rotablate, and then do a DEB alone, and then proceed to the proximal. And you saw that heavily calcified proximal large vessel, which we'd already rotablated. You see that eccentricity in the proximal segment. So I decided, of course, IVL 3.5 IVL was nicely positioned at all places and delivered now enough pulses. Having delivered enough pulses, went ahead with a 3.5 millimeter balloon, non-compliant balloon, to exactly practice what I preach. Look at it in 2 projections and see whether you got whether you actually got an indentation, and if you have. We finally removed that indentation, or believe we removed that indentation, went ahead and implanted a stent all across with a crossover to the left main, and finally at 26 atmospheres, I was left behind with a residual stenosis. Not good enough, so I went ahead with a 3.5 OPN balloon at 40 atmospheres, and now I was happy that I've actually taken that indentation away. Lo and behold, my 4th complication, there's a perforation. The patient is on Impeller on 4th, and again, stupidity of life. I'm explaining to you exactly what you shouldn't do. If you haven't judged the size of the vessel, if you haven't imaged it, it's a safety issue. It's not just a strategic issue, it's a safety issue. You will actually not go up with ultra high pressure balloons unless you know the size of your vessel. And you can't take it up to 40 atmospheres. Of course, went ahead, immediately got a graft master in, positioned it, blew it up. This time 3.5 OPN to 40 atmospheres inside the graft. No, sorry. So that is graft master, blew it up to 4 millimeters, got a great result. Perforation sealed, the patient well supported, and of course finally did the port and got a great result. Well, that was thankfully the end of the procedure after that 3 hours of 4 complications. Patient did well, of course, continues to remain well. Thankfully, I just felt that, I don't know, I'd got up from the wrong side of the bed. Had I actually not prepared myself well enough for each step that was going to be? Or perhaps so the lessons I've got to tell you is, of course, Follow the basics firstly. Of course, get up from the right side of the bed, be sure. Don't lose your cool prior to a complex case. Be in control of the situation, keep calm. Start the case well, start the case with positivity. Follow the basics, which I've demonstrated that I did not. And of course, Impeller does save lives in such situations. And if you really have these situations, it's the only device which can actually be put in easily through large bore accesses and yet be taken out soon after. This is a patient who actually, I think we perhaps left the device in for 24 hours only because of the amount of stunning and complications that he'd had on the table. Had this been an uncomplicated procedure, we get the devices out on the table. But the only other reason we feel that the devices in some patients have to be kept it because patients pay 20 lakhs for this. They need to be seen, they need to know that there's something in the patient when he comes out. Otherwise, they'd never know where the 20 lakhs went. Thank you very much for your attention.
Ashok, midway through your presentation, I was going to make a note to tell you you have shown us everything except for a perforation. But you got that also. Everything possible in a coronary case is right there, all in one. Amazing. In the way you handled it, it was a long work, 3.5 hours, but a lot of learning. Yes, Dr. Claire.
Oh, you have to. It's MSAs. That's what I should have done. I should have looked at the MSA. And it's been clearly demonstrated that would have been expanding in the other direction as where the eccentricity is. And that's why you saw the rupture right on the top. But the MSAs would have been good. And it's been demonstrated that MSA actually dictates outcomes far greater than ellipticity index. And that's why we never chase residual stenosis beyond a particular point.
Any comments, Hani?
It's a fantastic case, and the way you have acted as a leader, keeping everything cool, hats off to you.
People are
That's right.
speechless.
I think you got out of the bed from the correct side, because
Yep.
this is as bad as it gets, and despite all the challenges, I think the final result is great, and as you said, the patient's doing well.
I'm wondering which is the right side of the bed. We need to do that tomorrow also. Thank you very much. A big hand, and we'll invite our next presenter, who's now the leading light for hemodynamic support in our institution, and he's leading our heart transplant program, Dr. Vishal Rastogi, a very close friend. Over to you, Vishal.
And by the way, a proctor for Impeller as well.
Thank you, Dr. Mathur and Dr. Seth. We have had two very good presentations in the session, and in fact, the case that Dr. Seth showed, it qualifies for this presentation as well, which is the on-table crash. If you don't have Impeller in place, probably the patient would have crashed at any point of time. And the case I'm going to show, I'm sure a lot of you have seen this case, but still the message remains there. So we did a case of TAVR in a bioprosthetic valve failure. It's a 66-year-old female who has multiple comorbidities and a failing perimount bioprosthesis, ejection fraction 40%, AV of 0.3. Of course, she was planned for valve-in-valve TAVR. The operators knew beforehand the complications during valve-in-valve procedures are high because of the coronary occlusions and multiple other issues. So a lot of precautions were already in place. Of course, this is the pre-picture of the patient. You can see the LV is fair, 35-40% ejection fraction is there. There's a good stenotic valve with a large gradient. And this is what was done. The patient was taken and the balloon dilatation was done, and you can see the echo next. Of course, the patient had hemodynamic collapse. It was just out of the blue. We don't know what hit us. And of course, what would have gone wrong? Possibly a cardiac tamponade, a cardiac rupture that can lead to this standstill, or sometimes this bioprosthetic valve, which just gave way to a severe acute regurgitation, and the myocardium simply fails to contract after that. Of course, this is a catastrophe. Immediately, the CPR was started. So that brings to the point that these cath lab crashes are actually very catastrophic situations and mostly unforeseen. Despite being prepared for everything, you don't really prepare yourself for everything. So these can be air embolism, it can be slow flow, no flow, it could be vessel or chamber perforation, which can lead to tamponade, or it could be vessel occlusion, valvular dysfunction as occurred in this case, or in a chip case, even hemodynamic collapse can occur. And of course, it is very important to support this patient immediately. Otherwise, if you could just continue to do CPR, the patient is not going to make out of the lab alive. As you know, that the myocardium is getting very heavy injury at that time. So it is very important that you support the patient and also correct the underlying problem. Otherwise, the patient will not be saved. So what is the aim of mechanical circulatory support here? It is to resuscitate the patient and maintain end organ perfusion. Not just myocardium, but also other organs are taking a hit as the circulation is not being maintained. It is very important that it allows you to perform the stabilizing measure, which is like you can do the angiogram, you can do the autoperfusion, you can do revascularization, you can do whatever is needed to support this patient. And also, it will limit and reverse myocardial injury. It may unload the left ventricle and influence the cardiac remodeling also, if it's a device which supports that. However, the mechanical circulatory support is indicated only if the procedure, if the hit is acute and it is reversible. Otherwise, it will not salvage the patient if you don't have anything correctable in the patient. So what are the devices available? We know that we have these devices available to us: IBP, Impeller, tandem heart, VA, ECMO. We don't talk about VAD or transplant in this scenario. But if the patient is crashing on the table, the device of choice is ECMO. Why? Because it's an ideal device it is effective. It supports the circulation, which maintains the tissue perfusion. And also it is very versatile. Irrespective of the patient's rhythm, the device is able to support this system. And it is very easy to use and can be quickly implanted on the cath lab table itself. And of course, in our scenario, it is not very expensive as compared to the devices that we've been talking earlier. VA ECMO is you take the drainage cannula is into the RA, and you take blood from there to the oxygenator to the aorta. It is percutaneously implanted, and it has some negative effects, like it increases the filling pressures and preload, as Sanjog was talking earlier. It increases the afterload and increases the left ventricular wall stress. So of course, it's not a good cardiac support device. In fact, it is not a cardiac support device at all in this sense. It will be loading the left ventricle and further worsening the hemodynamics inside the left ventricle. But it is a very good circulatory support device because it provides 5 to 8 liters of flow per minute, which is sufficient to sustain the body while you are doing everything, whatever is required to sustain this patient. So coming back to our patient, the patient was having this earlier stable rhythm, which you can see on the left side. And then from there, there's just a chaotic rhythm. You don't know what is happening. You just do CPR. There's some flows, some pressures are there. You stop CPR. There is no pressures, and just the chaotic ventricular tachycardia, ventricular fibrillation. Multiple shocks were given, and then it was decided that we should immediately institute ECMO. So ECMO was functional in the next 5 minutes because it was all prepped and available there on site. You can see that CPR is going on, and the ECMO cannula is there in the patient. And once the ECMO is there, now you are at peace to perform the procedure. You cannot just leave the patient on ECMO and forget about it. You have to, once the circulation is supported, you have now all the time in the world to do the procedure right, implant the valve and make it competent so that the patient stabilizes. How to initiate ECMO quickly? It's a teamwork. You require the shock team with people who are well-versed with the system. It is very important to keep ECMO and circuit primed, because otherwise it takes time to call the ECMO from the OT or from the place where it was kept, and then take it out and prime it, and then start it. By the time, you would have lost a very precious time. We should have a crash eCPR pathway, and we should do mock drills also. Otherwise, you just forget about these things, and you may not be able to do it when it comes to that. Of course, it's not just you perform ECMO and forget about it. You have to anticipate and manage complications also. We know that ECMO is providing blood retrogradely into the aorta. blood from the heart is getting ejected antegradally, and if the lungs are not all right, and if the heart has improved over a period of time, the brain will be supplied by the inoxygenated blood, and the ECMO will be giving oxygenated blood to the lower part of the body. Not a good situation. So either you reduce the flow of the ECMO and try to wean off the patient now, or you have to do something else. You have to talk about, very important that limb ischemia is one of the most important complications here, because these are very large bore devices and they occlude the flow to the distal lumb, and then it is important that you take the distal access cannula at the same time and perfuse the limb through the same ECMO flow. Another important point which Sanjog was talking about is the pulmonary edema on VA ECMO, because you're loading the ventricle, you're increasing the afterload of the ventricle. That's why the patient has pulmonary edema, and then it is important that you have to vent this left ventricle, which could be done by many of the measures which are available here. Here, coming back to the case, as the valve became competent, the ventricular tachycardia stopped and the patient stabilized. Of course, it is a long work after that. Patient was shifted to the recovery, and there the VT stopped, the pressures are now acceptable. Of course, the left ventricle is still very stunned, and it required some time to improve the patient. The patient had severe acidosis at the time, and then gradually over a period of 84 hours, the patient improved and the ECMO was weaned off. And after that, the patient improved and he was discharged 3 days later. The key is to think fast and institute support early. As soon as there's a crash, you have to assess the situation and assess what is degree of support that is required. Whether the patient can just improve with IRBP, or you need something more than that. And in fact, if the patient is crashing in front of you, then probably ECMO will give the best support here. You should know your device, what is the access site, what is route, what are the limitations, what is the time required to initiate the device, and what are the possible complications and their management. It is very important to keep doing mock drills to keep the skills sharp. And once supported, you have to keep working to correct the underlying problem, because that's what is going to save the patient. Thank you. So this was acute severe AR. As you dilate this calcified prosthetic valve, the simply leaflets, they just degenerate. They're not there.
Can I?
After that, we have stopped doing pre-dilatation in these cases.
The monitor which you have showed in your PowerPoint, what I saw when you dilated the balloon paced fast, and that pace leads to VF, and that leads to cardiac arrest. And there may be associated, because of balloon dilatation, you have AR also, severe AR also. So in prosthetic valve, we are putting balloon dilatation. If you need, take a smaller balloon so that your device goes, rather than taking balloon leading to AR. And here VF is there. If you see the monitor, still you can go back your PPT. There is when you overdrive, pacing faster to inflate the balloon, and then there is a VF, and that's a cardiac arrest.
So it's known factor that if you have severe aortic regurgitation, you would actually also have collapse and VF. And it's intractable, and it only became tractable after the valve was inserted, after the transcatheter heart valve was inserted, and AR decreased, and the VF storm disappeared at the same time, half an hour later. The second aspect is that dilatation of the valve, or bioprosthetic valve, has been advocated to measure the leaflets, see how far they go, the VTC, etc. But it's a very bad idea. It's a very bad idea. And by the way, this was so there's not even small. This was a 16 millimeter balloon for a 23 millimeter valve, and that is small, but it's absolutely a no-no. There is absolutely no need to dilate bioprosthetic valves.
These bioprosthetic valves are known to do this. The bioprosthetic valve fracture, there are two schools of thoughts. Should you break the valve before or after putting the TAVR valve? we've done it plenty of times before and stopped doing that exactly for this reason. Because when the valve causes AI, then it's a mess and it becomes such an emergent situation. Did you have like ECMO in the lab prepped?
Yes.
Because otherwise there is no way in 5 minutes, at least in our lab, that we could get an ECMO in. So preemptive these things.
Sure. After our first complication, which we lost the patient, unfortunately, then after that, it's a protocol in our lab that we have, whenever there's a TAVR case happening or any structural case happening, we have ECMO in the lab, which is primed and available.
Sure. Yeah.
So there's that was a nice case, Vishal. What I know about the aortic valve is it starts with the letter A. It's about where it stops for me though. So I have no idea.
It's the most proximal lesion to cross.
Yeah, I know, right? There's something about a valve in there. I think it starts with the letter A, but that's all I have for you.
And it's never a CTO.
Well, I mean, you know, it's like what a TAVR. It's a big stent. You just put it in, right? So the comment I was going to make was about the MCS. This is a unique situation because you know that you are going to correct the anatomic train wreck immediately. But that is not to suggest then that ECMO is a good idea in severe acute AI, right? Or any sort of aortic regurgitation, because retroaortic flow with high afterload in the setting of aortic regurgitation will make the AI much worse. In this situation, I think you knew precisely what the problem was. You had to correct it. You knew how you were going to correct it, so it makes sense to get some sort of support on board. Even if you load the LV for 5 minutes or 10 minutes, who cares? Because you're going to put a competent valve in moments later. That's different than, say, the patient who has a blown LV with bad native aortic insufficiency, as you know, as a hemodynamicist, as you know, where that's sort of a hole, right? We don't have a great device to treat severe cardiogenic shock with a failed aortic valve and bad wide open AI. At least I'm not aware of one that's really all that good. The Impeller doesn't work that well. The ECMO doesn't work that well. Tandem's a retroaortic return. Balloon pump doesn't work that well. So, you know, there is one device actually that's being developed by Cal Aliswad that is an antegrade perfusion device where you actually go across the septum, down the mitral valve, and then back out the aortic valve. So what you're doing then is pulling from the RA and spitting straight out the aorta. And the belief is that you'll get around the head and neck vessels with a large cannula. But obviously that takes an awful lot of technical ability to be able to get to these things.
So Joe, you know, we just to point out to people that this patient would not have survived just because of ECMO if the valve hadn't been fixed.
The fix here was the valve.
So that's the whole
the fix
issue
is the valve.
around it. It has to be fixed right then and there.
That's exactly the point that I'm making, is that the fix here was the valve. This is the rare circumstance where some sort of circulatory support, whatever it is, was helpful for that 5 to 10 minute period while you were getting your valve primed. You could make the argument, let's say you had a Lucas device and you just did a bunch of really good CPR during that time, but you were very adept at TAVR and you got a new TAVR valve in. And I mean, I don't know the answer to this because I don't do structural. You know, would that be as good or comparable? You know, maybe. The Tandem Life set, which is not available in India yet, but there's interest in bringing it, is basically a big 4-liter tub of saline with a very stripped down pump. So it's a single dial, all it has is RPMs on it. It's meant to be nurse run at the bedside. There are 2 cannulas that come inside it. You basically fill the tub with 4 liters of water. You drop the cannulas into the tub of water. You flip the tub over so that the cannulas are submerged in water, and you hook the other end up to the pump, and it's primed in 4 minutes. So that's your 8-minute ECMO, if you will, right? Where you crack it open, you get one person filling it with saline, you drop the cannulas in, you hook it to the pump, and you say go. And it will prime by that time you have access. You have your things dilated up to reasonable size, and you just pop the cannula.
No, you're talking about tandem heart.
Yeah, so it's effectively...
So tandem heart is a very long procedure because you need a septal puncture.
No, that's not what I'm talking about. You're talking about tandem heart. I'm talking about tandem life. Okay, so there are 3 variations of products from Lebanova. There's the transeptal tandem heart. There is the Protect Duo or other RVAD cannula flavors. They have several of them. And then there is tandem life, which is a it's not called ECMO. It's truly speaking circulatory support.
Because
but it's
doesn't have
it's a VA setup, right? Where you cannot put an oxygenator on it. No, you can actually. You can. They have an oxygenator on it. It's very short lines, so you have minimal temperature drop across your ECMO lines. So you don't need a heater, cooler exchanger. There's no sweep. There's no gas, right? Unless you have the oxygenator on. If you have an oxygenator on, you have your standard sweep and gas. But the key is that it primes quick, and you can get a 17 or a 19 and an 18 up on the other side, and you're on 4 liters.
Okay, thank you guys. This was a great discussion and an excellent case, Vishal. Thank you. Big hand to all of you.